We are at the end of, towards the end of day one, and we've saved the best for the last, I guess. Um, so it is such a pleasure to be here and have uh, the the principal investigators of the two biggest trials on PDA management here with us um, to debate on this topic that we have been debating on different stages across the world for for quite a while. So the way we want to do it is that I would take the opportunity for the next 10 minutes to briefly summarize some of the recent evidence. We've had quite a bit of evidence come out in the last little while, highlight some of the issues that have created some controversy, confusion based on that recent evidence, and maybe end with some questions that will open up the floor for further discussion and debate. Okay, so before we start, we'll again take a step back and just stare at these numbers. And these numbers do not include the two biggest trials that these gentlemen have run recently. So to date, before the Baby Oscar and the Benedictus trials came out, we've had 138 randomized trials on PDA management that have randomized almost 12,000 preterm infants. That includes almost 5,000 in PDA prophylaxis trials, almost 7,000 in PDA treatment trials. But yet here we are today, still trying to answer these two questions: when to treat the duct? If yes, with what to treat the duct? But even before that, the two big trials, the Benedictus and the Baby Oscar, have kind of brought back this big elephant in the room, whether to treat the duct at all. So there has been a lot of discussion in recent years about the fact that neonatal care has changed so much over the last 40 years. Should we be even looking at the older trials, and should we be even bringing those older trials in our discussion in PDA management? Fair enough, acknowledged. So I thought let's look at some of the recent trials, the trials that have been published after, well, post-pandemic, to see what these trials tell us. So obviously, the two big trials are the Baby Oscar and the Benedictus trials, and I'm kind of focusing on trials on early ibuprofen use because this is the most commonly used medication for PDA management. We can talk about the other pharmacotherapies in our discussion, but I'll kind of limit it to early ibuprofen use. So apart from these two trials, we've had the trial CAPI trial from Europe and the PDA randomized controlled trial, which was a single center trial from Ireland. Now, just to quickly summarize, I know both Dr. Gupta and Dr. de Boode will go into this in more detail, but these two trials were fairly similar in their basic methodology, randomized extremely preterm infants with a PDA size of more than 1.5 millimeters that was shunting left to right within the first 72 hours to either early ibuprofen treatment or control. The Baby Oscar was a superiority trial, randomized almost 650 babies, and essentially found that there was no difference in their primary outcome of death or moderate to severe BPD. While the Benedictus was a non-inferiority trial that, again, failed to establish or rather established a non-inferiority of expected management versus early ibuprofen therapy. But in fact, if we take a closer look at their primary composite of mortality, NEC, or BPD, early ibuprofen seemed to fare far worse compared to expected management. And we will again go into further detail as we go into the debate. But that has raised some very pertinent questions about, are these drugs that we are using safe to use in these very small babies? Now, on that note, I was recently updating my Cochrane review that we published in 2020. And based on the criticism that I had of including all trials, I did a sensitivity analysis of the post-pandemic trials. So you see the four trials that I talked about. And now when I combine the results of these four trials on early ibuprofen therapy, there is a 36% relative increase, which translates to a 4% absolute increase, statistically significant increase in mortality with early ibuprofen. Now, this is not even hot off the press because this is not submitted yet. So hopefully this will come out sometime later this year. But I'm pretty sure this is going to create a lot of debate, discussion, and stir, because this is the first time that we are seeing a statistically significant increase in mortality with early ibuprofen use when we look at the recent trials. When we look at some of the other outcomes, BPD, there was no difference. Severe IVH, there was no difference with early ibuprofen. So that raises the question, if ibuprofen is bad, then shall we just stop using it? So I'll just briefly mention what happened when centers actually stopped treating the PDA. Now, this was an observational study that was published a couple of years back from Montreal, Canada, where they looked at outcomes of two comparable sites. One site continued their usual approach of medical treatment and ligation, while the other, based on some of the recent evidence, had changed their practice to a complete non-intervention policy. Interestingly, what they found was that in the slightly older preterm infants, between 26 and 29 weeks of gestation, there was no difference in death or BPD in either epoch. But in the smaller babies, less than 26 weeks of gestation, there was a 31% increase in death or BPD in the center that stopped treating PDAs. While in the other center, the outcomes in these small babies did not change. Quite interesting and contrary to what the trials suggest. Again, a very similar study from the United States. Again, looked at two epochs. The first where they would diagnose and treat a PDA early. And then in a second epoch, they moved to a more conservative approach, reserving treatment only for increasingly symptomatic infants. They had a fairly comparable cohort with a mean gestation of around 26 weeks. And even they showed that the outcome of BPD and the composite of BPD or death was far worse in the second epoch, where they moved to a more conservative strategy. Again, contrary to what the trials suggest. Third is this really interesting post hoc analysis of the PDA Tolerate trial, which was a multi-center superiority trial done mostly across centers in the United States, where they looked at outcomes of babies who were eligible to be enrolled in the trial, but were not actually enrolled because of lack of physician equipoise, because physicians felt uncomfortable waiting until 7 days to enroll these babies in the trial, and therefore these babies got treated earlier within the first 6 days. Now, these babies were smaller and sicker compared to the ones who were actually enrolled in the trial, but despite being smaller and sicker, these earlier treated babies had better clinical outcomes. Again, contrary to what the trial suggests. Finally, we have had this very recent meta-analysis of the effect of a persistent ductus on some of the longer-term clinical outcomes. And there is a clear suggestion that prolonged exposure to a patent ductus arteriosus in the smallest babies significantly increases the risk of BPD-associated pulmonary hypertension. Which raises this question that, do we have an unimportant problem, or do we just have, unfortunately, a bad treatment for a problem that might be important in some babies? And that is something that we are going to discuss today in our debate. So, do we have the polls, by the way? Okay. So we have a couple of polls just to get a feel around the room. So first, Let's think about this preterm baby who's 24 weeks of gestation at birth, day 3 of life. Again, bad lungs on high frequency oscillation, high mean airway pressure on 60% oxygen. We do an echo. The PDA size is 1.6 millimeters, unrestricted, pulsatile left-right shunting. Would you medically treat this duct? Well, we have a job on our hands for the next hour. Okay. So kind of looks like the yes, as I speak, the yes is slowly going down. So people are feeling less and less confident after some of the data that I showed. Um, so majority is still no, but it's around 50%. Yes, 33%. Not sure includes me, 15%. Okay, let's just hang on to that thought. Now, let's think about another preterm infant, slightly older in gestation, 27 weeks, day 3. Fortunately, just on CPAP, almost room air. We do an echo, and we have exactly same echo findings. 1.6 millimeters, unrestricted left-right shunt. Would you medically treat this duct? Okay, now we have a clear answer, like this. No confusion whatsoever with this. I see 5% still wanted to close that duct. I like it. Uh, no one is unsure about it. That's great. Oh, the yes is going up a little bit, but still, I mean, like this is a clear winner. Now you're just playing with me. Okay, 90-10 is I think the best we can get in today's world. Now, interestingly, if you look at the recent trials, both the patients are eligible to be treated if they were randomized to the treatment arm. So we should kind of take a step back and think about this. That has been one of the issues with some of the recent trials, especially the inclusion criteria, and something that we will go into further discussion, is the overemphasis on PDA characteristics and less emphasis on the actual effects of the shunt volume, which is maybe a slight deviation from how we practice in real life. And the second is the lack of consideration of clinical signs when we decide to treat or not treat a duct, which is again a deviation from how we approach a duct in our day-to-day practice. So something we can go into further discussion. Now, to address the first question, all of you who would do echoes or have seen echoes of ducts in preterm babies know that PDAs in preterm babies come in all different shapes, sizes, and forms. And therefore, in the same baby, on the same echo, depending on how you measure it and where you measure it, the size of the PDA may vary from a small PDA to a large PDA based on the traditional cutoffs that are used in recent trials. And that is something that is probably underappreciated at the bedside when we pin our decisions on one single value of a PDA size. The second is the clinical characteristics. Are there clinical clues from recent randomized trials that could help us target our therapy or tailor our therapy? Now, Dr. Ron Kleiman, who loves kind of going into all the different data of recent trials, have presented us with these two elegant post hoc analysis of the PDA tolerated trial and the trial CAPI trial, which essentially lead us to the same direction, that it is the extreme preterm babies who have a hemodynamically significant PDA, but the ones who are also mechanically ventilated for more than 10 days are the ones who are at the increased risk of BPD or death. So maybe if we have to target a population, this is the population who might give us the biggest bang for our buck. So that leads to the following questions that are up for debate. First, should we treat at all? My thought, at least the evidence suggests that every PDA that is deemed moderate or large sized does not require treatment. The big question is, should we just ignore all ducts and just stop looking at them? Second, if not, who may benefit from pharmacotherapy? Should we have a gestation age cutoff? Should we delve a little bit more deeper into the echo criteria beyond the PDA size? Should we start looking at clinical criteria, which has in so far been ignored in clinical trials? Should we have a postnatal age cutoff beyond which we should just give up trying to close a duct medically? Finally, is the big can of worms. What should we use? Is ibuprofen still our first choice after the data that is starting to come out? What about paracetamol? I didn't go into the evidence, but we can talk about the evidence and its implications in our debate. Is it really safe? Safe as we think it is, but ineffective in small babies? Does it really work in the babies who really need their ducts closed? Or should we think about bringing back indomethacin in some of the babies despite all its side effects? And the final question is, when should we consider just getting rid of the duct definitively? So I'll leave these questions up, and maybe I'll invite Willem to present maybe your part, and then we can bring this up. Thank you.
Thank you, Souvik, and thank you for the organizers for inviting me to this really excellent day, this conference. I'm really honored. And I will give my perspective from the lessons I've learned from the Benedictus trial and maybe contribute to trying to answer the questions that has been raised by you. Because, yeah, it's already for 60 years that we're debating about what to do with the patent duct, especially in the smaller infants. And there are two ways of looking at it. First, for an active closure, and it seems very plausible and logic to do that. In a normal situation, without a duct, the blood going to the lungs equals the blood going to the rest of the body. So the pulmonary perfusion equals the systemic perfusion. In case there's a large transductal left to right shunt, you have an increase in pulmonary blood flow at the expense of the decrease in systemic blood flow. And from that, it's very plausible that there's an increase in pulmonary injury, bronchopulmonary dysplasia, the pulmonary hemorrhage, increased need for respiratory support, etc. But also on the other side, more renal failure, more cerebral injury, necrotizing enterocolitis. So that was forcing us to think we should treat the duct. And there's all different approaches, starting with the prophylactically already being addressed, pre-symptomatic, so there's an echocardiographic screening program, or only doing something when there's a clinically apparent PDA or there's a condition suspicious of having a PDA. And the earlier you start, the less risk of the prolonged exposure of to a PDA. However, the redundant adverse effects of treatment is the highest if you give prophylactically, and the longer you wait, you will have a less risk of the adverse effects that are redundant. So what should we do? If we look at all the RCTs, we've learned that treating the duct with ibuprofen, indomethacin, it doesn't change anything in mortality, bronchopulmonary dysplasia, necrotizing enterocolitis, etc., IVH. It only proves that there's a closure of the duct. And because of that, it was decided that treatment of PDA is not associated with a significant reduction in severe neonatal morbidity. So why should we wait for a spontaneous closure? It happens. It takes longer in the more immature babies. However, there will be a spontaneous closure. And for that, it was getting more interesting to start and wait the expected management. And in this situation, you've got an immature baby. And the immature baby has a higher incidence of a PDA. But that same immature baby also has a higher incidence of BPD, IVH, necrotizing enterocolitis, etc. But that doesn't mean that it's the PDA that is causing those adverse outcomes. So it was more popular. However, the evidence for this approach is very scarce and contradictory. And if you have a good focus, you focus in on all the RCTs that have been performed in the past, and you look at the control group, so either getting placebo or no treatment at all, there was a median of 50% in the control group that eventually were treated. So you don't compare treatment versus no treatment. So it's not a systemic review of treatment versus placebo. It's a systemic analysis, early versus later treatment. So is it still valid that treating the duct doesn't improve the outcome? This is why we started the Benedictus trial. It's an international multi-center randomized controlled non-inferiority trial in preterm infants, less than 28 weeks, with a PDA, a diameter more than 1.5 millimeters. Perfectly said already by Dr. Mitra, that is not a good parameter to express hemodynamic significance. It's not a parameter that tells you about the transductal shunt volume. However, for being able to do and perform a clinical trial, we had to do this. There was the expectant management, no treatment at all to influence the duct. You know the patient was randomized, so it had a duct, but we don't look at it, we don't treat it. And the other group was the early ibuprofen group, within starting within postnatal age between 24 and 72 hours. And the composite outcome was mortality and or neck, a Bell stage 2A or higher, and or a moderate to severe bronchopulmonary dysplasia, all assessed at a postmenstrual age of 36 weeks. We had a total of 273 patients in the trial, a median gestational age of 26 weeks, a median birth weight of 845 grams, and 136 patients were in the expected management group, and we were very lucky that we succeeded in a real low open label treatment, only one patient, so 0.7%. To keep you in mind, it was for all, the median for all RCTs in the past was 50%. If we look at the treated arm, the duct was closed in after the first course in about 55% of the patients, and that is consistent with other numbers in literature. Let's go to the primary outcome. As already mentioned, there was a absolute risk difference of minus 17.2%, so less necrotizing enterocolitis, moderate to severe bronchopulmonary dysplasia, and or death in the expected management group. That was not what we expected. We expected non-inferior, but it looks like it's superior. Well, if you talk to a statistician, they say you can't call it superior because it's a design of non-inferiority. So we call it non-inferiority. It doesn't matter if you do the intention to treat or per protocol analysis, it's exactly the same. What is interesting, this is a composite outcome, but let's look at the components of the primary outcome. So it's mortality, it's the neck, and it's the BPD. And it shows you that it's the BPD that makes the difference, minus 70.6%. So it's less BPD in the non-exposed the group, so the expectant management group. For the secondary outcomes, no difference concerning the IVH, also not for the more severe IVH, grade 3 or higher, renal failure or pulmonary hemorrhage. What was very striking was the difference in sex. Especially we saw that when males were exposed to ibuprofen, you had a very high increase in absolute risk. The risk was 30% higher in the male population. So these results, in my perception, They suggest on harm that's associated with early ibuprofen exposure that is largely driven by a higher incidence of moderate to severe bronchopulmonary dysplasia in the early ibuprofen group in comparison with the expectant management group. And the question raises, is the cure more harmful than the condition itself? And we know there's a relation between ibuprofen and pulmonary injury. And I always thought that's logic. You give ibuprofen because of a PDA, and that's why there's a pulmonary injury. But it looks there are data that show there's a direct relation, not related via the PDA. Observational studies in extremely preterm infants show that there's a direct relation. Preclinical studies also show that there's an inhibition of angiogenesis by ibuprofen in umbilical vein endothelial cells in the retina of neonatal rats, and also the cardiovascular development in zebrafish is influenced. And very interesting, recently a study was published from China where they measured angiogenic factors prior to and after a gift of ibuprofen. And what it showed was a decrease in angiogenic factors. So in my perspective, I think there are different clinical phenotypes. And that's what I have learned from the Benedictus trial and all the other PDA trials. Suppose we got a hemodynamic significant PDA. We can discuss about that for 1 week, I think. But you decide to treat either with cyclooxygenase inhibition, so either ibuprofen or indomethacin, or with peroxidase inhibitor, paracetamol. One phenotype is you have a successful closure. Another phenotype is you've got a failed closure. And the third option is there will be a partial or a temporary closure. The first one, I think the treatment was beneficial because the reduced exposure to the PDA outweighs the potential adverse effects of the treatment. However, if you got a failed closure, it might be injurious because you've got both the prolonged exposure to the hemodynamic significant PDA, but added to that, it's also the adverse effects of the treatment. And in between, you don't know. It's depending on the balance between the duration of the exposure to the PDA and the potential adverse effects. So this is my perspective. I do think we've learned that it can be safe to not treat, to have an expected management. It might even be superior for the whole group. However, I think we didn't prove that you shouldn't treat any patient. From a hemodynamic perspective, I think it's still plausible that there is a selection of patients that need treatment, and that's the next step we have to dig into. That's why we are exploring the data from all the echocardiograms within the Benedictus trial to only select the patients with a high transductal shunt volume and do this analysis again and see what the results from that will be. So this is my view on the Benedictus perspective on the recent trials.
Thanks, Willem. This is great, and like thank you for just starting to uncover some of the nuances around PDA management through your experience of the Benedictus trial. So now I'll invite Dr. Gupta to provide his input on his experience from the Baby Oscar trial and in general around his experience with PDA management, and then we can go back to some of the questions that we started off.
Thank you, Souvik. And thanks, Stephen, Vicky, Catherine, the organizing team, for inviting me to this wonderful conference. This is the second one. The first one was in Stockholm, which was a great experience, and I think you matched it. It's great interaction and great talks. So having set the scene by Souvik and Willem, I think it's more about probably going a bit into what we found from the Baby Oscar trial. So no disclosure as it is. Now, we know that we are in search of treatment for a PDA. And the PDA treatments have been conservative. It has been prophylactic, it has been symptomatic or early targeted, as we say, or surgical, or not do anything. So we are trying to find one. And those who are from Scotland, they have heard about the story of the Loch Ness Monster. So clearly, we believe there is a treatment, right? But where is the treatment? And I think this is something we're trying to find the Loch Ness Monster in our neonatal world to find which treatment is going to work it out. So are we able to find one? I won't spend a lot of time. That is the Dr. Barbara Schmidt's trial on the prophylactic treatment, the largest trial to date, but about a good 25 years old, which came from Laura Ment's trial, which was primarily done to give prophylactic indomethacin to reduce the IVH, as you heard from Souvik in the morning. And based on that, because there was a PDA closure, it was done, and the primary outcome was at 18 months. It showed no improvement in the long-term outcome, and hence the practice gradually dwindled. That, as you know, in UK and Europe and Australia, indomethacin is not available because of the various side effect concerns and the non-availability as well. Again, I won't go into details because what it shows is symptomatic PDA reduces, need for surgical ligation decreases, severe IVH decreases all significantly, no effect on the mortality. Willem has very nicely shown, and this is a timeline when you expect the various complications due to PDA that we encounter. However, I think we need to take a step back. And I think the step back is important because when we talk about the trials down the line, we forget what was the situation when the trial was designed, right? So the trials that were done in 1975, the gestation was different, the drugs were different, the approach was different as now. Similarly, when our trials, I could say that the Benedictus and the Baby Oscar trial, when they were designed, the question was different. And I can tell you the first meeting I had for the Baby Oscar trial was in July 2011. And it takes that much of a time to start to finish and to present, and still we are waiting to present the long-term data. So the question at that time why it was designed was the world was believing, or particularly the hemodynamic world was believing, we have found a magic bullet. And the magic bullet was, there are benefits of closure of duct, but we are exposing unnecessarily 50% babies to the adverse effects of the treatment, which are not required. Why don't we select the babies who have a duct only to minimize the complications of the prophylactic treatment? That was the reason when the echo started becoming available on the bedside, performed by the neonatologist, we took the advantage, hold the probe, find the duct, give the treatment only to those who have a duct and not to others who don't have a duct. That was the starting point. And I think from that, the natural way was babies who have a duct and babies who don't have a duct, those who have a duct receive treatment or no treatment. So that is just a history at where we started. Clearly, the world has moved the last 15 years and the new questions have come up. This is just a summary of various treatment options. And if you look at whatever treatment you use, it certainly reduces the symptomatic PD and no surprises there. Only indomethacin reduces severe IVH. And when you compare the indomethacin and ibuprofen, the ibuprofen has an advantage over indomethacin because there is less risk of neck and less duration of ventilation. When the question was first raised, it is in 2007, I believe, yes, by Carl Bose and Matt Lahon, whether it is appropriate not to treat the duct. That was the first time they brought it up. And the question was, because there are no advantages of it, and there is no difference except for the closure of the duct and the IVH with the prophylactic approach, and for the asymptomatic, there is no difference at all except for reduction of the symptomatic PDA. So what they were suggesting in their commentary, treatments to promote closure of the PDA cannot be justified on the basis of proven benefit unless one finds a reduction in severe IVH with prophylactic administration of indomethacin, which is a compelling benefit to justify its use. That is 2007. So clearly, the equipoise started, and since then, there were, you have read a number of commentaries, and this is a lovely work from Shazi Bombal and Bill Bannett, which, as Willem was saying, the contamination has been very high, and when they restricted the trials to less than 50% contamination, what they found was, what they found was that there is a ductal patency which certainly reduces, the IVH reduces. But when they restrict to under 29 weeks, since 1990, they found that other CLDs are increased, but the IVH decreases. But if the treatment is restricted to less than 5 days, there was a reduction in the IVH and the ductal patency, but no difference in the chronic lung disease. So clearly the benefits were lost, which were seen otherwise, and even by restricting the number of trials which are below 50% contamination, what we were seeing is as you are seeing here. So the design of the baby Oscar trial, when it was for babies between 23 and 28 plus 6-week gestation, less than 72 hours old, have a large PDA on echo. And I just like to clarify that the large PDA was defined based on what the evidence was available. A duct that is more than 1.5 millimeter. The work done by the Sydney group, that is Dr. Nick Evans and Martin Clucko, at that time clearly defined that ducts which are more than 1.5 millimeter in the first 24 to 48 hours, they all required treatment down the line in their study protocol. And hence 1.5 was a cutoff. In addition, if you look at Harling's data, they looked at the flow pattern. So if a pulsatile flow, which is a high systolic, low diastolic flow in the duct, which reflects that the shunt volume is high as an indirect surrogate, and that would mean the sensitivity of these ducts is unlikely to close down the line, and its sensitivity was well over 75%. So for the baby Oscar trial, we combine these two criteria, the duct size of more than 1.5 and pulsatile flow to be eligible for randomization. The ibuprofen was standard dose 10.55, control was placebo, and the primary outcome was death by 36 weeks or moderate to severe BPD at 36 weeks postmenstrual age. Now, this is just a flow chart, which if you could, which you could see down the line. It is the left side. If you see inclusion criteria, there is one criteria which is that the clinician was in equipoise for enrolling the babies. Why is it important? There could be a baby who is with a PDA having a very refractory hypotension, no point randomizing because this baby needs a treatment. There is a baby who is in a little bit of oxygen or a CPAP, only with a small amount of it. And the clinician believes that this baby, I don't believe it requires treatment. Both these extremes were not eligible, but if the clinician is in equipoise, should I or not, they were eligible for inclusion in the trial. Others I have already mentioned to you. The short-term outcomes is what I'm going to be presenting. We have completed the health economic evaluation, which is in going to the press, and the long-term outcome data is under analysis because we have completed it. If you look at the characteristics, it's a large trial, which is 653 babies, and we use the minimization. So what the minimization was, we controlled and balanced the groups for each week of gestation for the size of the duct, depending it is 1.5 to 2 millimeters, 2 to 3 millimeters, or more than 3 millimeters, and whether baby was receiving invasive ventilation or non-invasive support or no support, and gender, site, and many other factors that were used for minimization. So both the groups are completely balanced. And hence you see that the postnatal age randomization is more or less similar for baby Oscar and blind ductors, which is coming to about 57, 56 hours. But majority of the babies were randomized in the last block, which is on the day 3. So I say 48 to less than 72 hours. 2/3 of the babies are randomized, as it is a normal practice that babies get randomized towards the end, the end line. A large number of the babies were below 26 weeks, and over 300 babies in this trial are below 26 weeks. Okay, so both are balanced, and 26 to less than 29 were again about 169 and 171 babies in each group. Mean birth weight 839 and 852 grams, and the size of the PDA is well balanced. But if you look, more than 2 millimeter is about 75% of the babies. So only 25% were less than 2 millimeter, majority more than 2 millimeter, and all of them with a pulsatile flow. Mode of delivery comparable, male 55%, 54%. CRIP2 score without temperature was about 11. And if you see, about 2/3 of the babies were receiving invasive ventilation at the time of randomization. Now, the question was, why did we include babies on the non-invasive support? I think that as the trial was moving forward, which happened as it was happening from before, the trend was changing, and we are ventilating less and less babies. This was an opportunity where to include these babies to get an answer whether a group of babies who are on non-invasive support would benefit or not from the treatment or randomization. And hence, these babies were part of it, and I'm glad that we were part of it because it throws some important answers to it. So 2/3 of the babies were on invasive ventilation and a third were on non-invasive. As you saw already, the primary outcome was death by or moderate to severe BPD at 36 weeks post-menstrual age, 69.2% ibuprofen, placebo 63.5%, adjusted risk ratio for all the minimizing factors as seen below, and the p-value was 0.104 and there was no difference. If you look at the individual components of the primary outcome, death 13.6% in ibuprofen arm, placebo 10.3%, adjusted risk ratio 1.32, 0.92 to 1.9, and a p-value of 0.128. And moderate to severe BPD, again 64.2% in ibuprofen, 59.3% in placebo. Difference is not significant. I won't spend a lot of time in short-term outcomes because there's no difference in all of them, except that the need for the treatment, medical or surgical, it was much lower in the treatment arm, which is ibuprofen, and less so in the placebo arm. Others were all comparable. Now here is a very interesting slide. Because we could compare by gestation, it was the primary outcome I'm showing here by gestation. So for each gestation, if you look at, there is essentially no difference whatsoever between the two arms. And the numbers are quite reasonable. If you see babies who are 23-week gestation, there are almost about 60 babies in this. And same way you can see for each gestation, it's quite a balanced group across it. Now, if you say that the size of the PDA, are these babies with just about a less than 1.5 to 2 millimeter ducts? No. 1.5 to 2 millimeter, they were almost about 160 babies, which is showing no statistically significant difference. 2 to less than 3 millimeter ducts, again, no difference. And more than 3 millimeter is again about 80 babies, which is again showing no difference, right? If you look at mode of respiratory support, invasive ventilation babies, about 400 babies on invasive ventilation, no difference. Non-invasive support, about 230 babies, no difference. So it's a very good clarity that the primary outcome, whether it is invasive or non-invasive ventilation, size or duct, there are no differences, whatever it is. Pre-specified analysis for the necrotizing enterocolitis based on the size of the duct. If you look at, no difference, and overall the diamond is right bang in the center. Now, spend a little bit of time on this. Now we look at the components of the primary outcome at the same way as we saw the composite outcome. If you look for each gestation, on the left side is shown in the moderate or the severe BPD. There is no difference whatsoever, right? Size of the PDA randomization, again, you are seeing it on the forest plot, the middle one. There is no difference in each of them. Mode of respiratory support, if you look for the moderate severe BPD, no difference. But there is a trend, if you see overall, which is in favor of the placebo. But look at the mortality. And I think Souvik did a great job because this has been something that has been in the mind, that there is a trend moving towards the mortality. And all the trials that we look at, it is a trend, but not a clear-cut demarcation there. And this is an important message going to come out from here. And this right side cartoon shows something important there. If you look at babies below 26 weeks or over 26 weeks, no difference in mortality. If you look at the size of the PDA, which is small, 1.5 to less than 2, or more than 2 millimeter, no difference in mortality. However, the trend is favoring the placebo. But if you look at the mode of respiratory support, babies on invasive ventilation, if they are treated, there are 400 babies, right? You are seeing the risk ratio of 1.43 with a 95% confidence interval of 1.01 to 2.01. Now, clearly, this is on the right of it and not crossing the line. So babies on invasive ventilation tend to be doing worse with the treatment for the PDA with ibuprofen in the first 72 hours in terms of mortality. If you look at the non-invasive support or no support, these babies, if they're receiving the treatment, there is a trend in favor of the ibuprofen. Now, we don't know because it is not significant, but it requires, this is a hypothesis generating, because are these a group of babies where if you treat, they increase the BPD, but they reduce the death? We don't know, but this is something that is an interesting finding. So in summary, early targeted treatment approach, there is no evidence of benefit of early targeted treatment of PDA with ibuprofen in this group of babies randomized for the trial. And early targeted treatment, it does increase the close of insignificant PDA and reduces the need for surgical closure. Now, some of the things which Souvik has already touched upon, I will not going to go into details, And the question that comes is, which are coming around globally, are the correlation between PD and neonatal morbidities. There is data from the observational studies that infants less than 25-week gestation or 750 grams should be there. I think we have 300 babies below 26 weeks, which says that the findings that I have just shared with you. Magnitude of PD shunt, is it moderate to large? I think we have shown enough that a large number of babies, which are almost 75%, that means 450 babies, they were having a shunt which is high enough because of the size, more than 2, and a pulsatile flow. Now, prolonged exposure to moderate to large shunt, it's a question, right? Then I'm glad that Willem is looking into this data, because we did a point echo at 3 weeks, not a continuous echo. And I think it will be good to look at the exposure to the shunt and see what the effect it makes. Infant is exposed to prolonged duration of invasive ventilation. Now, clearly, we are seeing that the data which is from non-Kleiman, I think it is showing that there is a group of babies where if they are ventilated for long, there could be a benefit of treatment from there. Now, the question comes is, can we ever design an ideal trial? The ideal trial is 100% closure and 100% open ducts. So that is not possible, right? So the expected arm, ideally, or the control arm, we cannot achieve this, except if you go for a device closure in the treatment arms and don't treat the duct at all in the conservative arm. That is one way of looking at it. And the limitations are that the difference in prolonged PD exposure beyond 7 days between study arms, typically, if you look between the trials, is about 20 to 40%. And you can see across the trials, that is the difference we get, not 100%. The closure rate in the treatment group ranges 55 to 70%. And I think that is what we are seeing in the trials that is there. Relatively late timing of the open label medical treatment could expose the infants to potentially damaging effects of the ductal shunt. So if the baby duct is not closed, then it is staying open for a longer time, and that becomes again a confounding factor. So these are the limitations, but this is the beauty of the pragmatic trial. And I would take you back for the NeoProm collaboration. When this practice changed, because the oxygen saturation targets were moving to the lower limits at one time, and we started accepting below 90% all the time. But with the trials and high mortality, the pendulum has shifted completely. Are we there again? We don't know, but that is something to be looking for. So question is, why is the evidence contrary to speculation? Do we need to do better selection criteria? I think we need to have a more clinical plus echo criteria required for a late treatment. For early treatment, the more criteria, in my view, if you put in, it becomes a confounder, because if you have to recruit from 30 plus units, it becomes a confounder when a lot of people are doing the scans. Are we intervening early? At the moment, from what we see from the trials, I think evidence is not in favor of early treatment. Pharmacologic agent, we know that the available medications have comparable efficacy, and a lot of trials have shown ibuprofen is comparable to indomethacin and ibuprofen is comparable to paracetamol, but do they matter a lot more? That is something to look from the pharmacodynamics and kinetics. What is the choice of primary outcome? I think when the trials were done earlier on, we were looking at the drug efficacy. We give the drug, does it close the duct? That used to be the question. Then we started looking at clinical outcome, like what you've just shown. But I don't think we should need to stop here. What the parents want, and I think it was lovely talks in the afternoon, the parents, what they want is, how is my child doing down the line? And hence the long-term outcome is very important for the trial, which hopefully we should be able to present in the next few days. Limitation of the evidence, contamination, sample size, closure rate of PDA. I think it's a natural course. There has to be pragmatic, because we can't make an ideal trial. The heterogeneity is bound to come in, but the power of this study is very important, and hence recruiting to the sample size becomes important for the power to make sure that if we repeat the trial, we are able to get the same results again. Before I finish, I'll just bring up, that there are various scores being suggested, and they have been used. There is a benefit of it, but that are single center experiences, and I think we couldn't replicate it. And we can't replicate in the multi-center trials because of the heterogeneity and the inter-observer variability that might come in. The size is having a good sensitivity of 81%, as I mentioned. The flow also is quite sensitive from Harling study. This has already been shown by Willem, that in the group of babies which are over 10 days and ventilated, that is probably where we are moving to from the current evidence. And slip that in here, because what you see that these ventilated babies who are over 7 days, they tend to have an increase in the BPD or death. But early on, if you treat it from the data, what has been presented by Dr. Ron Kleiman as a postdoc data, it does not show any difference in terms of. So probably going early may not be the right way forward. Ibuprofen, it has been associated with a BPD, but at the same time, the duration of the PDA, the longer it is, the more risk of the BPD. And we come to a point where the duct is open for, say, 3 weeks or 4 weeks, the baby start developing increased right-sided pressures or RV failure. That becomes even a more difficult situation. So as I think we already mentioned, selection of the babies is becoming more important at which babies to be treated. But rather than leaving forever, I think we need to also select the babies for closure early on rather than when they go into pulmonary hypertension. So this is a lovely work which has been from ISAMA. If you look at death or severe neurological injury, we need to find the sweet spot. Observe to expected PDA treatment ratio. If it is too low a treatment, it is not good. Too high a treatment is not good. What we need to find is a sweet spot of by selection of the babies which would benefit from the treatment and improve the outcomes. That is what we are interested in looking at. And I think these are some of the future research directions. Exploring the natural history of PDA is very important. New trials, probably looking at a symptomatic PDA, which is beyond 7 days, and the criteria could be fine-tuned. Long-term follow-up is very, very important because that gives the right answer for these babies. And a subgroup of infants at the highest risk of morbidity and exposure to PDA needs to be studied with appropriate sample size, minimum contamination, and treatment with high efficacy for closure of PDA. That is the ideal way moving forward. I know this debate, this dilemma is not going to finish over here. It will continue, but at least we should stop doing more harm to our babies, because this is important. That may not be good for the babies, but at least we don't harm the babies. Thank you very much.
Thanks. Thanks, Samir. That was excellent. And thank you both for sharing your thoughts and experiences from these large trials. I mean, it's fascinating, isn't it, that whenever we start thinking that we understand the physiology, a large trial comes and humbles us all with all these unexpected findings. Now, as we go back into the questions that where we started off, essentially, on what to do with this duct. One thing I would like to clarify right off the bat is that we have used the term treatment about 100 times today. But I often struggle with the term treating the duct, because we often use the term synonymously with closing the duct. And at the end, treating the duct, essentially, by treating the duct, what we mean is that we are providing a therapy which is harmful, partially effective, in our attempt to close the duct. And that is probably where some of the problems start. So any thoughts on that before we go into the questions?
I fully agree with you. It's not duct treatment, it's PDA management. I think that we're really talking about. The problem is, if we're talking about treatment in the ideal situation, as already addressed by Samir, you would like to have a trial where treatment is 100% effective in a very homogeneous population with a high transductive shunt volume, and that you compare with no treatment at all. So that's going to be very difficult. My problem right now is, should we treat at all? The first question.
Yes.
From the data we have now, I'm reluctant to treat. However, that doesn't mean I don't treat any patient at all. I think we have to be very selective. My question, also the questions that have been arrived, when there's a prolonged exposure to the duct, if you're longer than 10 days ventilated, that's the real important duct. Is it the duct, or is that a proof of the immaturity of the baby, because the more immature babies have the more immature lungs and will need more respiratory support for longer times. So it's still a matter of debate. Is it the duct itself and that need to be closed and then it will be better? Or is it one of the factors you try to take away? You tick the box, but is it really going to give a different outcome, or is it still an immature baby? So if I have to answer, should we treat it all? Well, based on the results of the Benedictus trial, we've made a new national guidelines in the Netherlands. In the first week, we don't screen, we don't treat. After that, to be honest, we don't know. Only if there is a situation we don't like, because it might be related to a duct, we do an echocardiogram, but then we're a real problem, because if there's a duct, what are the factors you decide to treat or not? We can say we decided it's going to be a pulsatile, non-restrictive transductal blood flow pattern, together with a retrograde diastolic blood flow in the descending aorta distal to the patent duct. Okay, then that's the one you want to treat. But then is the question, how?
Okay, so I'll just hold the thought for a second.
Yeah.
So I think that kind of answers one of the questions here, and that was, is PDA shunting not dangerous, or is the treatment as such related to higher risks than the disease? So we kind of addressed some of that. So essentially, to answer the first question, I think it is, we are not there yet, as you rightly pointed out, to say that we should be ignoring all ducts.
Yeah.
Okay, so if that is the case,
Sorry,
then
can I hold you there? Your question about the treatment, when you mentioned the word treatment, I think it's very important, because we use the treatment even for conservative, right?
yes,
Non-medical treatment, conservative treatment. What is conservative treatment? I think what we are saying is a non-medical treatment, but we are still doing the other things, correct? Now, coming to the first question again, should we treat it all? I would bring some spanner in the works there, and that is, we give leeway for brain to develop because we know it is immature, we don't expect. We give leeway for kidneys to mature because we know they are immature. We give even for development for the baby, because we say that it's a corrected age for development, has to be on such and such. We give leeway for that. It is quite probably, I mean, it's a pendulum, how we are shifting is that, is it a duct which is, again, we need to give time for it to mature and take its course, rather than seeing and treating because we can find a drug to treat it. And hence, the question comes is about right selection as when it causes a problem. That is a treatment, I think, in my view now. And so treating all, clearly, I don't think what we have learned is probably that is not the right way forward, because treating all is not an answer. But selecting the ducts which are causing a secondary problem is probably where we are moving to, however we define it.
May I comment on this?
sure.
Because it's still very difficult, because in my perspective, if I would have a intervention that would treat the duct 100% and it without the adverse effects, I think I would choose for that in a baby with a high transductal shunt volume, because from a hemodynamic perspective, I don't find it plausible that it would be beneficial to have a high pulmonary perfusion at the expense of a low systemic perfusion. Well, I don't see the benefits of that. So I do think we shouldn't treat it, because we don't have a treatment that can effectively do that without adverse effects. So that's why I decide not to treat. But that doesn't mean the duct doesn't need management.
Perfect. So essentially what you're saying is that since we are stuck with the BAT therapy, we have to be a bit more selective. So at least we can all agree that we shouldn't be treating all ducts, but we also shouldn't be ignoring all ducts. So it's not a willful ignorance, but rather a watchful waiting and carefully selecting which ducts need some form of management. Is that a fair summary?
I think that's very true. I think selecting based on the symptoms is important, rather than based on the echo is important.
Okay, which kind of nicely brings us to the second question, which is, whom do you think would benefit? And you've kind of both alluded to that a little bit. So if you have to give the audience a take-home message that based on what we know today, based on what we presented, all the scary ibuprofen data that is coming out, what would be the audience going home with in terms of whom uh, should be selecting in order to, like, what are the ducts we should be selecting out and trying to manage?
I think that's a million-dollar question. The reason is, uh, having seen the results of the early treatment, we are seeing more harm. So clearly we are moving away from there. So where are we moving to? Now, there are two ways of moving forward. One is either we actively go in babies who are, say, more than a week or whatever it is, and see whether there is a duct, and then we start taking an action accordingly. Or we move forward and say that, okay, baby is ventilated, baby is in heart failure, baby has other symptoms or signs which match with the symptomatic duct. We look for a duct. If it is there, select those babies and we move forward. And again, when we are suggesting, it is a way forward from the current, what we know in the current gestation that we are worried about. But we will certainly need more appropriate, convincing data from well-designed trials, whether that approach is also beneficial or it causes harm. But as of now, probably that looks a more plausible approach.
I do agree with this. However, now you've selected the patient with the high transductal shunt volume, not on the early phase, but on week 2. Then you want to treat. What have we got in, what is possible, what we can do? Ibuprofen. The chance of an effective closure in that specific patient, because it's probably the more immature baby, is not that high. So you have to use higher dosage with a large risk of non-effectiveness. So that's worrying me because it's still what I'm also practicing because I don't know yet what else to do. However, maybe it's a transcatheter closure. However, you're confronted with a baby less than 1,000 grams. Is it safe? Probably they can say it's up to 100% effective to close the duct, but is it safe? Because that's also what you want. So that's the dilemma I'm in right now. What would be the best way? So it's still, we have to find a way to have a safe option. And maybe to allude on this, paracetamol is often considered as an alternative for ibuprofen because it's less toxic. I'm not sure about it because we're inhibiting the pathway for prostaglandin synthesis. So there's the cyclooxygenase inhibition, but just downstreams, there's the peroxidase. So the paracetamol is affecting the same pathway. So why, and there are some, well, preliminary data that show us that it's not harmless. So we have to dig into that also. So just saying ibuprofen is bad, move to ibuprofen, that's the best way. I'm not sure. I think they're equal in their potential adverse effects.
Okay. So I'll just, Samir, I'll challenge you on that thought. So you said that we should definitely, based on the data, we should be moving away from early treatment, but we shouldn't be moving away from all treatment. Some of the babies would still need duct management. I'll try and stay away from the word treatment. Some babies will still need duct management, not early, but later on. But as you pointed out in your own data, and just Willem pointed out that the more you wait, you're losing out on options because none of those drugs really work at a later postnatal age. And by that time, the smallest babies already have been exposed to a high volume shunt for a while. So the damage probably already has been done. So what is the point exposing the babies to any of these drugs anyway? So should we have a postnatal cutoff beyond which we shouldn't even be trying to use any medication?
I used to believe that, right? However, we have come across babies well into 6 weeks, transferred to us, or 6 or even sometimes more, transferred for the closure. But because the baby has been transferred and evaluating, found that, okay, fine, let's give a trial of, and in this case, paracetamol, because clearly there is some data from the observation that paracetamol could be useful. And we have found babies, even at 6 to 8 weeks, who close duct after a course of paracetamol, and they avoid the ductal the cath closure. So we have not doing any surgical ligation for years. And the cath closure is the way forward, and it can be done in up to 750 grams. So our interventional cardiologist is very keen to do it, but we try to stop it and hence find it the right time for the right baby when we can send it. But I would still say, if you speak, I mean, it was lovely talk about looking at the family concerns. You talk to the parents and you say that, okay, your baby is here. Now there's a duct for which it was sent. We are going to go for a closure through the cath, and you explain that, or we give another course of medical treatment. They invariably say, can we try one more medical treatment and see if it closes? So I think parental wishes are equally important as long as we are not doing harm over and above what is acceptable.
Still raising the question in that specific patient, or should we just wait?
Yeah. So I think I was trying to deflect that, but but yeah, coming to the point, I think it is when we talk about the BPD, I think it is very clearly getting divided into two types. One is based on the damage to the lungs, and second is the flow-driven BPD, which is secondary to the PDA, which is most common. And getting to a point, what you have just asked is babies who develop a bronchopulmonary dysplasia secondary to increased flow due to PDA is a difficult situation, because these ones are the babies who can develop pulmonary hypertension with the RV failure. And then it becomes impossible to even close with a device, because you'll have to wait and give pulmonary vasodilator and see whether we can manage these babies. We don't want to get to that stage. We have to stop it very early. And that was the point where I think what we have to do is that babies who are ventilated, for example, I'm just picking the things from the arbitrary. Babies who are ventilated over a week or 10 days, whose oxygen requirements are not coming down. We know, okay, what is happening. These are the babies we should be then looking at. Is there underlying large duct? Is it contributing to it? And I think taking into the consideration the cardiac function, coping with it, decreased preload or increased preload, and the shunt volume, taking all into account, we need to decide whether these babies should be subjected to treatment, and it is worth trying a course of treatment. If it closes, it would reduce the chances. If it doesn't, worry is high, not wait for that long, but go for a closure with a cath. That is kind of an approach that we are taking nowadays.
Okay, so on that note, there was, and this is related to one of the questions here, is that so you have this baby, 2 weeks old, um, stuck on high mean airway pressures, invasive ventilation, high oxygen, and has a large duct. With all the risks of ibuprofen and the potential risks of paracetamol and the possible lack of efficacy, would you rather consider trying a course of low-dose dexamethasone?
Yeah, it's a very good question. And in our national guidelines, we said that in a patient with prolonged respiratory support and it's signs of bronchopulmonary dysplasia, we first have to treat the lungs and give corticosteroids before giving indomethacin, ibuprofen, or dexamethasone specifically for the duct. I think the focus should be on the underlying pulmonary problem and to treat that first.
Yeah.
If then still it's considered to be an important factor, I wouldn't use ibuprofen or whatever. I would go for a transcatheter closure in that specific patient.
So I think that's a big shift in mindset, isn't it? Because previously it was, the thought process was that first look for the duct, get rid of the duct, and then deal with the lungs. But now what I'm hearing is that maybe we should first deal with the lungs. Once you give the steroids, obviously the baby is extubated, and now everyone calms down because the baby is now on CPAP, feeding and growing, and then you give the duct a few more weeks to mature, and then it goes away, right? And if it still doesn't go away, and if it's still big, then no point meddling around with medication, just go for definitive elimination of the shunt.
Exactly. And well, we're neonatologists, have a lot of dogmas, and we think if you got a large duct and the heart is enlarging and you have to treat it. But we have seen in patients the duct closes by itself. However, if we wait and we got a necrotizing enterocolitis in that specific patient, they say, okay, that's because of the duct. But no, I don't think it's that simply causally related. It's far more complex than that, to be honest. Yeah.
Okay, so we have been talking about, so I am cognizant of the time, we have 4 minutes left, but we have been talking about the persistent duct in a small baby. So there's a question on early treatment. So would you treat an extremely preterm baby in the first couple of days of life if the baby is hypotensive and there's a significant duct causing a systemic steal?
Answer is yes. This is symptomatic baby, which is only going to benefit from the closure of the duct. And I think the standard treatments still stay the same. A symptomatic duct where baby is hypotensive and not responding otherwise is going to require a closure, whether it is by medicine or it is by the device. It has to be closed, otherwise this baby doesn't come out.
I'm very sorry. Mostly I agree with you. The simple answer is no, I wouldn't treat the duct. I would find out what's the reason. The hypertension doesn't tell you anything. You need some kind of cardiac output, and from that you have to decide what's the problem. So the negative, the retrograde flow can be caused by a lot of other pathologic mechanisms. So vasodilation in every circulation. So no, I wouldn't treat it. Yeah.
So I think the question was very clear. It's a duct-dependent hypotension. Are we going to treat it?
I don't.
And I think
I don't believe there's such a thing as only duct-dependent hypertension.
I think we have come across these situations time and time again, that these are the babies when sepsis is ruled out, there is no other AV malformations, the baby is hypotensive, and you have tried the usual inotropic supports, baby is not responding, and ultimately these are the babies who would need duct closure. So I think there's a proof in the pudding. And obviously, you have to rule out the other common scenarios which can cause a hypotension and probably look and evaluate the baby. But these are the babies who do require. And in our trial, in fact, these are the babies who were excluded from the trial because they were definitely going to require a treatment. And the clinician was not in equipoise in these situations and hence did not randomize these babies. So I think that was the point, right? Thank you.
So I think your data where you're looking bit more closely into the shunt volume and the effects of treatment might shed some light. And some of the other trials, like the one that we are currently running in Canada and the US, where we are looking at the shunt characteristics and clinical characteristics, might give us a bit more information on this particular scenario where we really want to believe that all the problems are because of the duct and therefore elimination of the duct should solve the problem, but we haven't yet proven that. So I think at that point, we should be honest about the lack of evidence, sit down with the family and talk about the pros and cons and make an informed decision. Sorry, I'm kind of going back to where we started the day with family values, but I think it's a nice segue to end the day with making an informed decision with the families in those situations.
Fully agree. Thank you.
Thank you.
I think that brings us to the end of the day.